Good afternoon, everyone. Today I'll be presenting a rare case of painful monocular vision loss. 30-year-old male patient presented to our outpatient department with sudden onset of loss of vision of left eye for past 3 days. There was associated history of pain and photophobia. There was no history of trauma or any other systemic illnesses. The patient did not give any significant drug history. On ocular examination, his visual acuity was 6/9 on right eye, and left eye there was absent perception of light. On external examination, there was mild protrusion of the eyeball of the left eye. Right eye had normal findings. Cornea, anterior chamber, and iris showed normal findings. Apart from that, pupil showed grade 1 relative afferent pupillate defect in the left eye, while the right eye showed normal shape and normal reaction. Lens was clear on both eyes. The intraocular pressure of the left eye was raised compared to the right eye. On fundus examination, there was cupping on both the eyes. Apart from that, there was tortuous vessels on the affected eye. Patient was then admitted to our inpatient department and underwent an array of investigations. His routine blood investigation was within normal limits. The coagulation profile was also within the normal limit. MRI brain with orbit was done using contrast and plane, which showed a well-defined type 2 hyperintense and type 1 hypointense lesion in the extracorneal space in the infromedial aspect of the left orbit. The lesion was encasing the inferior rectus and extending to the medial rectus and posteriorly to the orbital apex. The lesion shows enhancement on administration of the contrast. The lesion appears increased with Valsalva maneuver, and the lesion measured around 14 by 18 by 5 millimeter. There was thinning of the left optic nerve noted. Patient was started on eye drop timolol and tablet vitamin B complex on admission, and after examination on studying the MRI findings, the patient was then referred to higher center and was planned for surgical drainage. Thank you.
Thank you very much for an excellent presentation. We'll do the discussion later. Yeah, thank you so very much. So over to you, Dr. Lavanya. Can I have Dr. Harsha on the other side of the podium? Thank you.
82-year-old gentleman presented with the complaints of protrusion of left eye associated with pain and drooping since 3 days. He was already under oral amoxicillin clavulanic acid treatment when he presented to us. On examination, his visual acuity in left eye was 20/30 parts and right eye was within normal limits. In left eye, there was periorbital edema, conjunctival congestion and mild proptosis. Extraocular movements were limited in all gazes. CT orbit showed ill-defined isodense shadows in the left orbit, which is more towards the ocular codes. So the patient was treated with IV antibiotics and paracetamol, and after 24 hours of antibiotics, there was clinical resolution. So he was started on dexamethasone low dose. After 3 days of this treatment, there was clinical resolution of all the symptoms and extraocular movements were full. After 5 weeks of resolution of previous symptoms, this time the patient presented with swelling, pain and drooping of upper lid in right eye, but this time there is no chemosis and no congestion. There was a proptosis of 2 millimeters. And clinically the extraocular movements were limited in all gazes. CT orbit showed dilated superior ophthalmic vein and a soft tissue densities in between the medial rectus and the globe. MRI orbit showed ill-defined hypointense abscess in the right orbit between the eyeball and medial rectus and a dilated superior ophthalmic vein. Sorry, the images are not available. So with the provisional diagnosis of right orbital abscess with superior ophthalmic vein thrombosis, the patient was advised to take a neurologist consult to start on anticoagulants and the cause for the thrombus formation in superior ophthalmic vein. After starting anticoagulants, initially there was resolution of symptoms. However, on day 4 of the same treatment, there was exacerbation of symptoms and patient presented with severe pain and swelling. So he was started on low-dose steroids along with the antibiotics and anticoagulants. He showed improvement in terms of extraocular movements and proptosis. However, he developed secondary glaucoma, for which we added topical and oral anti-glaucoma medication. On subsequent follow-ups with the same treatment, there was resolution of the symptoms and patient improved. After the resolution of this episode in the right eye, patient was followed up with the physician. He has finished the course of anticoagulants and systemic workup was done, which was normal. 2 weeks later, he again presented with the same complaints in the left eye. So now a hypocoagulable state versus the infective thrombus dislodged from the distant site was kept in the mind and reviewed history. However, he has a history of multiple ulcers and the GI endoscopy was done, which was due to the H. pylori infection. He was advised to take gastroenterologist consult and immunologist consult. So the gastroenterologist told that H. pylori cannot cause an infective thrombus elsewhere. The autoimmune profile was within normal limits and he has completed the course of anticoagulants and he has no active eye infection. However, after 6 weeks, he was diagnosed with an interstitial lung disease for which he was kept on immunosuppressants, and in the subsequent 2 years of follow-ups, he has no evidence of eye infection. So the take-home message is, in any case of orbital cellulitis, we should check for the superior ophthalmic vein dilatation or the thrombus, and if there is a thrombus in superior ophthalmic vein, we should always rule out whether it's infective or due to hypocoagulable state.
Thank you very much. So he might have an attack again, probably a repetition.
This time he is on low dose immunosuppressants.
Okay, all right.
That's why he's not developing anything. Previously they just gave anticoagulants during that episode of cellulitis.
Okay.
After 3rd episode they kept him on continuous immunosuppression.
Perfect. Thank you so very much for